Hello everyone, this is Dr. Sanket Pisat, and today's case is about Ashermann syndrome or hysteroscopic synovitis. The incidence of intrauterine synechiae is on the rise these days because of multiple prior surgical terminations of pregnancies or MTPs as we call it. And I think this is a very worrying trend because as you will see in this case, it does lead to a lot of issues that become very difficult to manage later on. So, what we are going to look at in this case, first of all, this patient, I think she's about 28 years old. She has had only one prior MTP done, so one prior surgical termination of pregnancy by suction evacuation. This was at around 2 months of pregnancy, and at present she has got she has developed very scanty periods. So in of course we call it as hypomenorrhea, but in patient terms she has developed extremely scanty periods since the time that the MTP was done, and therefore our probable diagnosis is intrauterine synechiae. Okay. Now, the fact that she has got very scanty periods itself means that these synechiae or sticky adhesion bands inside the uterus are of significant nature. In a more severe case, she would have got totally absent periods, which would have made things even more difficult, both for the prognosis as well as for the patient in terms of her future fertility. Now, before going forward, let me emphasize that every time this is not possible to control while performing the surgery or while performing the MTP. So many times it is the patient's healing process also which determines to what extent these synechiae will form. And some patients do have one or two prior to pregnancy terminations and have absolutely no problem in conceiving in the future. So this is a lot to do with patient specific factors rather than entirely calling it an incorrectly done surgery. Now, as you see over here, the first view that you see of the inside, this is, as you can obviously understand, this is directly what we are looking at is the internal os. Okay. And at the internal os, you cannot see a regular internal os. You can see that it is completely blocked and there are 10 synechiae right from the internal os up. So usually we grade synechiae as between grade 1 to grade 4. And whenever there are synechiae right up to the internal os, this becomes a case of severe Ashermann syndrome, where almost entirely the whole cavity is going to be obliterated. So, how does one proceed with this surgery? Actually, you can see that we have been able to make out the internal loss at least, which is good. And rather than using a dilator, so the worst thing I think one can do is to try to use a dilator in this case. Rather than using a dilator, here we are going in with a 2.9 millimeter hysteroscope. So using a 4 millimeter hysteroscope, it's much better if you use a 2.9 millimeter, because this fine office hysteroscope is able to walk inside the cavity with minimum dilatation. So you can see over here, I have not used the scissor at all. I am simply using the 2.9 hysteroscope, and gentle maneuvering of that hysteroscope along with hand movements is sufficient, along with the distending force of saline, to open up the cavity and show me inside. Now here normally what you would see a very wide and spacious cavity, but you can see that the cavity is entirely blocked by synechiae. So right from the internal os all the way up till the top of the uterus, which is the fundus, there are only synechiae. Some fine blood vessels can be seen over here, but you cannot see the ostium on neither on the right side, neither on the left side. And so recreation of this cavity is going to be a difficult and challenging job, and one that must be done properly if you really want to restore the patient's fertility output. My choice of doing this surgery always has been the hysteroscopic scissors as compared to a resectoscope, because it causes minimal trauma, or actually zero trauma, to the surrounding endometrium. So you can see by gentle movements of the scissor, just snip out those areas which appear to be a little rare and less calcified, less fibrosed compared to the remaining tissue. And here you can probably see we have been able to show one ostium. As I have mentioned in my previous videos, minimum one ostium needs to be seen if you are going to exactly calculate how you are going to fashion the uterine cavity. So now we have two markers inside the uterus. We have got the internal os, and plus we have got the ostium on the right side. Then what remains is to find the other ostium on the left side and then finally recreate the cavity into a fully spacious or triangular cavity. So let's see how that can be done in this case. Once the ostium is found, and notice that every time it may not be possible to find the ostium as well. So it is lucky that we've been able to get the ostium on one side, but the question is whether it really is the ostium. So I gently divide the synechia around it, and you can see that ostium has gone away. That was not the ostium, and that is definitely not the fundus. We still have more synechia. So the scissor is poked, and you can see how the scissor is going inside. Now, this has to be done purely based on experience and judgment, where there is no way to exactly predict where the fundus is and how deeper you should go before you will perforate the uterus. Now, what I have visualized seems to be the correct ostium. So, I am going to consider that it is the ostium, and we will do the correction of the left half of the uterine cavity, which is seen now on the right of the screen. Notice how fibrous these adhesion bands are, and the scissor going inside slowly and steadily because of the distending force of the saline. The scissor is able to open up the spaces inside the uterus and create more and more space compared to what was there before. Also, the cutting of the scissor, you can see there is a very hard tissue which is being cut, because of which the scissor is finding some resistance. But my objective in the case is not to make the cavity good immediately. My objective is to find the other ostium. And I think I have been able to do that, because this now looks like the ostium to me behind the scissor at this position. Once I have located and finalized that this is the ostium, now what needs to be done is I need to correct the fundus and the lateral walls so that all elevations between the two ostia are gone, means that a septate-like appearance, which is actually due to fundal synechia, has been taken care of. And then I need to go and get the lateral walls to make it into a triangular cavity. Here it is important that a good hysteromat be used. We are using a hysteromat from Allen company. They have a new hysteromat with a continuous flow as compared to a pulsatile flow, which is there by most of the other Indian companies. So I find that very, very useful. And we are using a distension pressure of between 120 to 150, particularly in cases of severely T-shaped uterus and synechia. I prefer to keep a slightly higher distension pressure, maybe up to 150 or 160 even, for the simple reason that this higher distension pressure causes the walls of the uterus to move away. When there is no fibrosis, it is okay, the walls can move away even with less distension pressure. But with significant fibrosis like this, it makes it difficult to cut unless the walls have been separated well. And so I use a slightly higher distension pressure. Now you can see that using the right ostium as the marker point, I am going to trim the fundus using that line or that level of the ostium as my ending point. It is very difficult, or rather impossible, to say that I will not perforate the uterus at this stage. That is purely a matter of judgment. And also sometimes judgment can fail in the best of hands, which is why we always take a consent for laparoscopy also along with hysteroscopy in such patients, because you never know when you might make a mistake in judgment and there might be a perforation. Here you can see now some small fine blood vessels that are coming up, and this sign is encouraging, and it means that we have bypassed the area where there was fibrous tissue, and now we are moving on to a more vascular area, which is actually what we are looking for as the end point of our surgery. Notice that the hysteroscopic scissor, this is a standard Indian hysteroscopic scissors. You do not need to buy very fancy or very expensive equipment to do this. With a standard hysteroscopic scissors, notice that very small snips are being taken. So literally, this is like chiseling or sculpting the endometrial cavity millimeter by millimeter into its original shape. Okay, I am using only the knowledge of the depth of the ostium to decide how far I can cut And I am also controlling my cut based on the pinkish appearance as compared to the whitish appearance of the fibrous tissue. So here you can see, I can see the level of the ostium there in the corner, and I'm going to level my fundus until it reaches up till the level of the ostium. Okay, so gradually keep on cutting in very small bits. Take a moment to go back every now and then to see whether or not you are in the correct place and at the correct depth, and then you can continue your cut. Intentionally, I have left that little vessel there. Maybe I will cut it later for space creation. But here you can see now we are working on the left side of the patient and trimming up the synechia so as to reach the level of the tubal ostium. Here you can see that last cut, it resulted in exposure of blood vessels. So now I have to be cautious, which means that I'm probably closer to the myometrium, which again, like I said, is a good sign. But neither of the two signs can be considered absolute. That means that if you are able to trim the fundus successfully and you are able to create a near straight line between the ostia on both the sides, that also can be considered as an endpoint of surgery. But typically, we prefer to keep a slight indentation in the middle between the two ostia and not make the fundus completely flat. This is because the normal fundus is supposed to be arcuate, and if you make it completely flat, then what happens is you are predisposing her to a probable uterine rupture in the future, right? So here you can see I've gone up till the level of the tubal ostium. I'm cutting it. This video, which I'm showing, this video particularly is completely unedited. So there are no edits, and I have not skipped even a single frame of this video, and I'm not going to till the video ends. So here you can see I'm cutting the fundus, and this fundus seems to be even harder now. But I'm nearly at the level of the tubal ostium. So do I need to cut more? Maybe a little bit more, because this is not normal uterine tissue. This still seems to be, to my scissor and to my cutting hand, still seems to be quite dense fibrous tissue, and I feel I should go in a little more before I can stop the cutting. So I'm going to continue the cutting a little bit more. This actually is per se is based only on personal judgment, and it is literally impossible to tell how much to cut. Look at the cavity now. It is so much more spacious compared to what it was before, almost like a near normal cavity. Also, the appearance of this ostium nearly looking like a normal ostium, and appreciate the shape and size of the cavity now, which has become quite big. Now, what we need to do is we need to understand that these synechia are not always present only as anteroposterior bands. They are also present sometimes on the lateral wall of the uterus. So, as we do a lateral metroplasty, we are going to use the hysteroscopic scissors to perform lateral wall synechiolysis in this particular case. So, you can see over here, we are cutting over the lateral wall. Okay, from we start from the internal os up and cut all the way up till the ostium. Here, this is a block of tissue which majorly consists of fibrous tissue. And time and again, I have talked about doing excision of synechia rather than only incision of synechia, so as to not leave a stub of fibrous tissue behind, and to take out all the fibrous tissue that is there in that area, so that the patient has a best chance of conception. It is more difficult and more tedious to do as compared to the standard incision, but in my limited experience, it has proven very useful, and patients have got pregnant quite well after doing this particular surgery. Okay, so then this is now like the physiological correction, rather the organic correction of the cavity. You can see over here, however, that islands of endometrium are not many. So there are minimal islands of the endometrium. So we cannot promise this patient the world. We can tell them that this that you can expect good return to menses. If she's completely amenorrheic, the menses will probably be better, but promising the patient that she will conceive with such extensive synechia may not always be possible. We will have to give her a 3-month treatment with medicines like Proginova. We will have to give her intrauterine Foley's balloon for separation, and then we can only see what is the healing at the end of 3 months and decide what the outcome of this surgery will be. So you can see this is on the right side and on the left side. This again, now what we are doing is right lateral metroplasty, something that many young hysteroscopic surgeons find very difficult to do. But you can see it does not take a long time to master. You just have to insert the fixed blade of the scissor inside the cavity and keep making cuts from the internal os up to the ostium in one straight line. Now you can see the shape of the uterus is much better than before. The cavity has been widened significantly. This is the block of tissue that we are going to take out, and that completes the surgery as far as the organic correction is concerned. However, one more step is left, and this is what we've been doing now for quite a bit of patients. Some patients have very good results, some patients not so much, and some IVF specialists literally vouch for this therapy. So, for the cost, for the possibility of being able to give the patient maximum benefit, we do not really know whether it will work tremendously well or not. This is what we are doing, and this is subendometrial PRP injection. So PRP, for those of you who already know, is platelet rich plasma. This is derived from the patient's own blood. So it is not any foreign tissue. Blood is collected. PRP is harvested from that blood. It takes just about an hour's procedure in the lab. And this is now injected below the endometrium in order to stimulate the possibility of the blood vessels growing better after the therapy and the patient having more thick endometrium as compared to the thin endometrium that she had before and a better chance of conception. So this PRP is we usually inject it in four quadrants. This is the first quadrant, and then we wait for some time for the PRP to get absorbed. Then we fill up the uterine cavity again, and then it is injected at another site. So we usually do what is called as a four quadrant PRP injection. But remember, this is subendometrial PRP. The other way to give the PRP is to do this in the OPD, like an IUI. Here you can see the subendometrial wheel that is created when the PRP is injected, which shows that it has gone into the exact place that it should be. And this is so PRP treatment has been used by a lot of places. It has been used by dermatologists. It has been used in so many areas of rejuvenative medicine. And this also presents over here a not so expensive but quite promising therapy for those patients who have thin endometrium and who have synechia. So that is the second quadrant of PRP which has been injected. Then we inject into one more wall. This is the left lateral wall of the uterus, and about 4 or 5 cc is injected per wall. And this is the last wall into which the PRP is being injected. So now this surgery, almost it has been 8 or 9 months. Previously, the patient had very scanty menses. Now she has a good flow of 3 to 4 days and a flow every month. So psychologically, the patient is much relieved, and also she will be undergoing IVF in the coming month or so. So let's hope that she does well and the surgery becomes successful as its final outcome. So thank you all for watching. For those of you who have not yet subscribed, please subscribe to the channel to keep receiving more updates. And if you'd like to participate in our daily discussions, if you are a gynecologist, do visit our website. The name of the website is www.endogynetraining. So that's ENDOGYNE training.com, where you will find updates of our training courses in hysteroscopy and laparoscopy. And you will also find on the home page a link to our discussion group where you can also discuss pertinent matters related to gynec endoscopy, and they will be answered by many of our experts who are already there in the group. So that's it for this video. Thank you so much for watching, and do stay in touch. Do leave your comments on the video, or if you feel that something should have been done better or differently in this case. Thank you so much for watching.